Thank you so much for joining today. My name is Jason Hines. I'm CEO and co-founder of Gigasheet. We're a data analytics software and data company. And I'm joined today by John Hargraves, who's Managing Director of Strategy at the Healthcare Cost Institute and one of the best data analysts in the business. I think probably the most knowledgeable and experienced analyst I've worked with when it comes to claims data. And well, John, you want to give a quick introduction to yourself and background?
Yeah, hi everyone. I'm John Hargraves, Managing Director of Data Strategy at the Healthcare Cost Institute, HCCI. We're a small nonprofit, nonpartisan research organization based in Washington, D.C. And I've been here looking at commercial claims data, Medicare data, big claims data for my entire career, which, is now almost 20 years.
Wow.
A lot of data.
Well, that explains why you're probably the most experienced person I've run into in this industry. A little bit about Gigasheet. We were founded in 2020 when I co-founded this company. And today we are focused primarily on healthcare commercial market intelligence and price transparency data along with that. And we'll look at briefly our software platform today, but we'll be mainly talking about our data and different ways to analyze it and comparing it to claims data. And that's really where John comes in. The whole idea behind Gigasheet is to make working with really enormous and complex data sets easier. Frankly, if all this price transparency data were just a big Excel spreadsheet, that would be great. And it would add a lot more clarity to this complex market. We're trying, we strive to make it that simple to work with. We have a long way to go, but you'll see the progress that we've made today. And John, I'll let you talk a little about in more depth about HCCI.
Yeah, so HCCI, as I said, we're a nonprofit, nonpartisan organization, very small group, but we like to think we punch above our weight as far as the amount of analytics we get done. We were founded in 2011, really with this mission of shedding light on what's happening with employer-sponsored insurance costs. So this is a commercially insured population, and historically has been understudied because of data availability. We promote independent, nonpartisan research. We allow external researchers, primarily academics and policymakers, access to data, access to research on this population. To kind of highlight our mission is using data and analytics to drive improvements in the U.S. healthcare system. We believe healthcare claims data should be accessible, usable, that the information should be transparent, easy to understand. And it's really that key part, easy to understand, which I think gets lost sometimes when we talk about transparency in our modern parlance. And then that robust analytics can empower stakeholders to improve the quality and value in healthcare.
Cool.
What we do and how we try to achieve that mission is, we do a lot of data aggregation, data governance, and licensing, particularly around commercial claims data, also other types of data. We do thought leadership and original research. Please visit our website. We're always kind of posting new briefs and other kind of analytics on there. We do that throughout the year. Then we do government data analytics. So we are not just focused on commercial claims. We also do analysis using Medicare and Medicaid data. And then we do transparency. This is different than tick data transparency, but we do have healthprices.org, which is a consumer-facing price transparency tool. I say consumer-facing, but it also has a lot of value for employers, policymakers, researchers of just like how much does a given service or episode cost. And then we also do the Florida Transparency Initiative, which is the Florida State APCD.
Cool. Thank you. So for those who aren't sure what price transparency data is, or maybe just know a little bit about it, I'll give you a very brief history or background. The first rules went into effect around the price transparency data we're talking about, which is first it was hospital price transparency files in 2021, and then payer coverage and rates, negotiated rates in 2022. These rules went into effect at that time, and Gigasheet's been working with and processing that data since then. But to be honest, it was really a struggle. Many of these files were broken or malformed or just totally irrelevant. But over time, CMS has improved their guidance and the specifications around the schemas. Payers and hospitals have become more compliant as well. And so now the data does offer some valuable insights, and we'll talk about that today. So hospitals publish data. Typically, they're required at least once a year or when there are major updates to their contracts. And then payers publish every month data. What we're going to be focusing on today is payer published rates. This data, while it is called price transparency data, it is hardly clear or transparent in the sense that you could just open a text editor and look at the data. It's typically published in a format like JSON or JavaScript object notation, which is machine readable files. And that's where the term MRF comes from. Keyword being machine readable, not necessarily human readable. You can look at what's in these files, but it's hard to make sense of that. And that's a lot of what our infrastructure does, is processing that data. And we'll show you what's in these files, and then we'll talk a little bit about how to work with them. But behind the scenes, there's a whole pipeline of data collection where we, Gigasheet, go out to all of the payers' websites. They all publish these files, these machine-readable files. While there is a schema, a common definition, there is still a lot of variance in how these files are accessed, how many files there may be. Some payers publish thousands of files that must be combined and deduplicated. Others may publish a single file that's many terabytes in size. We perform that extraction, transformation, deduplication, and also remove zombie rates, which are basically where we may get rates for providers who would never provide that type of service. Classic example would be like a chiropractor doing heart surgery. There may be rates in these files for these combinations of clinical focus area and procedure that just don't make sense. And that can account for up to 90% of the data in these files. So if you were just to say, well, what's the average rate that United Healthcare has for a total knee? You may be including a lot of miscellaneous data that would skew the numbers. So we perform a lot of cleansing and extraction up front. We also do enrichment so that we can add details about the providers themselves, the organizations that they work for. As everyone knows, one hospital may employ hundreds of different providers, and hospitals themselves may have many different NPIs and even tax IDs. So we do a lot of entity resolution there as well. And then finally, when the data is cleaned and normalized, we can start to use it to do analysis and benchmarking. And that's really where we're going to spend our time today, is talking about how we can do that. Now, we do also incorporate Medicare geographically adjusted rates. We're not going to focus on Medicare or government plans today, but that is a capability that maybe we'll look at later. Primarily today, we're looking at payer published commercial rates and how to analyze that data. So this is kind of where we approached HCCI to really get some third-party validation. And HCCI holds one of the largest, I think you told me, John, databases, claims data. And they are certainly experts at this. And we wanted to kind of compare these. But I'll let you maybe describe the project that we came up with here.
Yeah. So, sort of HCCI's mission with transparency, obviously the tick data has been on our radar for a while since, the first files were published and we couldn't open them. We're data experts, and there's a technical issue with the JSON files and just the sheer size of these data sets. Becomes a technical complication and cost prohibitive for most small organizations. So we were happy when we have met Gigasheet and kind of realized we had this ability. They had figured out some of the technical issues, and we had the expertise in kind of thinking through healthcare costs and what we could do with this data. But one of the main questions since the first tick files were published was, is it a useful resource for the types of research we do, which is market analysis? Are these costs reliable? And so that was kind of the first objective of this project was, based on what we know on the claim side, which is negotiated amounts, and we know the services occurred and they got paid at a certain rate, how does that compare to the tick data? And is there a way for us to look at estimates we've calculated with claims data and try to replicate that with the tick data? And so that was, we said, well, that's a great idea. How do we narrow that scope? So We've done a lot of work on maternal health care and childbirth costs over the years, so we thought that might be a good area to focus in on, as it's the most common admission for the commercially insured. And yeah, kind of hospital service. So that's a little bit narrows down the provider list and just kind of the size of the analytic file we would be working with. And then we, kind of said, well, we could do it nationally, but let's narrow the geographic scope to again make, narrow it down so we could really get under the hood of the data and make decisions on, what do we have to do to clean this to get it to the analytic file. So we zoomed in on Pennsylvania as a state, which Gigasheet had already kind of had a lot of the tick data available for that state. And, it was fairly representative of the US as far as the types of geographic areas, urban, rural, other diverse state. And so that was kind of how we got to this research question of looking at the variation in childbirth costs for in the state of Pennsylvania within the tick files and how that compared to our commercial claims estimates for the same thing.
Yeah, that's right. And I think back to your first point, a lot of people did look at transparency and coverage data when it first came out or shortly thereafter, like in 2022, 23, and even into the early parts of 24, and just gave up and said it's worthless because they experienced much what you did, which is, broken files, lots of irrelevant data. But we've made a lot of progress since then, both on the publishers of the data as well as the government enforcement, and of course, companies like us in the analytics space. So there is a ton of data out there, and the first step was to gather it and assess like what we have. This came from about 11,000 files across 8 major payers that do business in the Pennsylvania commercial market. Turned out of those, about 2,000, just 2,300 of them had data that was relevant for this project. So lots of them, dental plans, vision plans, all kinds of stuff that doesn't relate to childbirth that had to be sifted through. But that still was about 1.6 terabytes of data and 30 plus billion rows. After cleansing, deduplication, it reduced it to 150 gigs, just under 3 billion rows, and we'll take a look at some of this data in a second. You can see the payers listed here. So definitely diverse, as John mentioned, with not just in geography and urban and rural settings, but also diverse in terms of big mix of payers in this market. Organization and provider linking. This is where we tie back the data that is published to information from the MPI registry, gathering things like taxonomy codes. This is also normally the step where we would integrate Medicare rates as well. We can see within the data, there were 132,000 NPIs and 51,000 unique, roughly 51,200, 600 rather, unique EINs. And we were able to resolve about 15,000, 16,000 of those to organization names based on public data like IRS filings and other public data sources in the entity resolution step, which allows us to map providers to organizations to networks. So you can start to get an idea of which providers are contracted by which carriers and under which plans. And the EIN can be a helpful point in that. The EIN and tax ID is included in the payer published data. Yeah, John, do you want to talk about this? And then maybe I'll just show a little bit of the data in Gigasheet so people get a sense of what we're working with.
Yeah. And so, we're starting with these still rather large files of cleaned processed tick files that were enriched. And remember, like when we're saying billions of rows, these are published rates. They're not like if you're used to claims data where each row is someone received a service line and then it kind of makes sense where you'd have billions. This is not. It's like how many, it's payer, provider, plan, and then for a given service, how much the contracted rate is. So it's in some ways a huge data set of aggregated data, which makes it a little different when thinking about it and how to aggregate or collapse this data and clean it. But the first thing let's just focus on Pennsylvania, where the providers are in Pennsylvania, and the DRGs are this range of childbirth and patient claims. First thing we know is we had to clean that. So it's always kind of like, we started with all these filters pretty broad to make sure we were capturing the universe of DRG-based billing codes. We know as leading zeros because this is payer submitted. There's always going to be this kind of double check, clean, make sure you're not removing observations you want to include. Yeah, this is, one of the things is make sure to look at the data as we did each step and then, test it out. So again, filtering on geographic and billing code, and then the type of rate. So within the tick data, it kind of lists if it was negotiated, derived, per diem, percentage charges. There's a whole variety of types of rates that can be published in those files. We wanted something that was, how much does this admission cost? And so we kept negotiated, derived, and fee schedule after checking to make sure that the values in those, for that types of rates made sense and seemed to be comparable. We excluded per diem because there is no length of stay, which makes it hard to take a per diem rate and calculate what the overall cost would be. Then percentage rates we also excluded because, again, it was hard to know what it's a percentage of. And so that removed some of the observations. And then lastly, we kind of made sure the facility type, the primary taxonomy was general acute care and patient hospitals, and that they were billing as DRGs and were institutional. So again, trying to get that data as clean as possible, as comparable so that the rates we're looking at, so we're not including things like a per diem rate and thinking a hospital has very low prices, but really we were only, if you're looking at per diem, that's not comparable to a whole stay. So just making sure, it's as apples to apples with the rates as possible.
Right. And I think whenever we're working with this data, that is a recurring theme. And as you can see here, this is about 2.9 billion rows of data for Pennsylvania. So this is all providers and procedures across the state in one giant spreadsheet. And you can see we've got the payer name and the billing information, but we also have modifiers, the setting or place of service. As John just mentioned, the different negotiated types, the rates themselves, if they have a Medicare equivalent in the physician fee schedule. We've also got a proprietary heuristic we add to rule out outliers or uncommon rate combinations. And this is what the data looks like after it's been processed. You've got the NPI taxonomy codes, the provider details, et cetera. So there are a lot of different facets here that, as well as plans, that you would want to account for, right? And this creates the possibility for a lot of different combinations, but by tightly filtering it and grouping it, we can sort of get closer to an apples to apples comparison. But if I do just like a quick aggregation on this data, you can just see, how it comes out. So Aetna is kind of publishing under two different names. And then you've got UPMC, of course, UHC, Highmark also publishing under a couple of different names. So a lot of work has to go into collapsing this and accounting for it accordingly. And you can see here the row counts, just the vast amount of data we started with. What we did is some filtering using just kind of basic filters where we filtered by billing code and got down to the MSDRG and created this subset, a smaller sheet that was easier to kind of get our arms around and that we knew had the filters already in place so that we could take a closer look. And this is just a fraction of the 2.9 billion rows at 126,000 rows. So much more manageable when it comes to analyzing and spot checking data like that. Speaking of standardization, I can talk about this or you can, John. It's up to you here.
Yeah, I mean, I just like to highlight one of the things after filtering with standard, we were, as you saw in the data, there were multiple high marks. There were multiple Aetnas, multiple Geisingers, and we're really interested in the variation in the rates. And there's a lot of duplicates, and things don't get deduplicated if they're under a different payer or plan or these provider, but it's not a real difference. So a lot of this normalization was to make sure we were, if we're seeing identical rates and they seem like they have the same payer name, plan, et cetera, that we're collapsing them. So we're removing this kind of, this duplication so that we can capture the real variation. And we're not seeing the same rate 100 times just because that's how the payer submitted it.
Right. And every step of our pipeline, it's like we run another deduplication because they always seem to slip in. And it takes many, many steps to get down to where you feel like, all right, now we're looking at clean data. And once we got there, it was time to take a look at different geographies. So this is really where your expertise came in
Yeah.
on your side. Yeah.
And so, as you saw in the file just showed, like, we have the geographic information. A lot of the work we do with our claims data is at a metro area CBSA. And so we use the 5-digit zip code to map on to the CBSAs in Pennsylvania. So we get sort of replicates the analysis we did in the claims. After cleaning and deduping, we created two analytic data sets. One is at the CBSA payer provider DRG level, and one was at the payer provider DRG level. Main thing is because you could have the same payer and provider, but they, in multiple CBSAs. We did see that some of these larger systems are just kind of one data set to look at that metro area variation, and another to just look at that payer provider variation. Both data sets had 150-ish providers. So these are hospitals, general acute care hospitals, organizations, and then 8 payers. And then we excluded, even after all this, we then looking at the data, and then we realized we had to exclude additional providers that were VA medical centers because they just kind of had a flat rate, were only listed for one payer, and it was unlikely that people were using those providers for this service, at least in a generalizable sense.
Right. So then it was time to try to go after some of these questions. And yeah, John, why don't you?
Yeah, and I think so. We just kind of went over a lot of the cleaning and thinking through, our thinking to get to this analytic data set. And all that was driven by these research questions of, how much do prices vary for childbirth in Pennsylvania across and within CBSAs, providers, and payers? The reason we started with a research question rather than trying to just, how do we want to clean this data, all the data nationally for every service, is because finding out the little intricacies, for inpatient admissions, for these specific DRGs, it's easier to make decisions. And so I would say, like, the same thinking would apply to any service, but some of the decisions might differ, because of the site of service. There's additional fields that are very useful within the tick data that were not relevant for this research question because we're looking at inpatient services, but the same kind of thing applies. I think one of our takeaways is the data cleaning should be informed by the research question. There's some standard data cleaning that can happen, but some of those decision points are really going to be informed by what you're trying to look at.
That's so true. I think with everything we look at, we try to maintain all the original data that's available in these files for reference, because just like you're mentioning, if we were researching total knees, we probably would have filtered out differently than, say, childbirth. And I think it's a bad strategy to just try to guess and make generalized guesses and throw all this stuff into a database, and you're forced to leave out things, which isn't good. So yeah, I think that's super important.
So back to the research questions, in the study we did with the claims data, we were looking at what the median childbirth price varied by X across metro areas. And then within the metro areas, how much did that price vary across hospitals? And then within the hospitals, how much did it vary? One thing that I always find hard to wrap my head around what they give these price variation questions is, well, it's varying by all these different, directions. There's geographic variation, there's across providers, there's within providers, across payers, like they all intersect. So it's the best way to kind of start to understand it. And so we kind of focused on these 3 ways of looking at it with some additional lens that we could add on the payer side because that's available in the tick data, but was not available in the claims data.
Right. And if you can go check out the Health Cost Institute website and the previous study that they did with claims data on childbirth showing that it can be twice as high within the same hospital, you can pay twice as much money. And that was sort of the study that drove us to say, well, can we see the same trends or additional details, or is it possible to replicate that with the transparency and coverage data? And so here's really where John came in and they did their work, which is very impressive, I think, anyway.
Yeah. So we had looked, in the analytic data set, we have all the childbirth DRGs, but with claims data, you sort of can implicitly weight the average prices or immediate by use by how many admissions of each DRG. One of the limitations of tick data is there's no measure of utilization. So, everything's going to be weighted the same if you're taking an average. There's no way to weight for use. with the data that exists in the tick data. So just to simplify things, we are focused on DRG 807, which is the most common childbirth DRG. It's 48%. So roughly half of all childbirths are going to be billed under this DRG in the commercial claims. A vaginal delivery without complication, also one of the lowest cost DRGs for childbirth. And if you're seeing the two maps, and honestly, the variation, so the data presented is all the tick data. The variation, when you look at all DRGs versus just DRG 807, is pretty similar across these CBSAs in Pennsylvania. Yeah, the dark blues tend to be the same. The middle tends to be the same. And then when you look at the price range we saw in the tick data, you do see some CBSAs with very low rates and some with higher rates. For DRG 807, range from 3,600 to 16,000. Compare that to the claims average, which was 11,000. A lot of the big CBSAs, the majority of the people living in Pennsylvania fell into metro areas that were close to that claims data estimate. So right away it says like, okay, this data does seem to align as far as the rates published in the tick data with the rates we're seeing paid on claims. For all childbirth, we do see a higher average in claims data, and we also saw a higher average in the tick data. That says when you include those other DRGs, they tend to be higher priced. So then we kind of looked at within the CBSAs, what's the variation in the hospital rates? So we're looking here is the ratio of the 90th to the 10th percentile of negotiated rates within each of these metro areas. One way to think about that is just like how many times higher is the high price compared to the low price. So for some of those very dark blue ones, it's 4 times higher. The higher prices the hospitals are getting is 4 times higher than the low prices. When we look at kind of the big ones, Philadelphia, Pittsburgh, Harrisburg, Scranton, they all were falling into the probably 2, a little above 2. So their high prices are twice as high as their low prices in those markets. That actually is very close to what we found in the claims data. Yeah. In the claims, for these specific CBSAs, things were, anywhere from 2 to 2.5. And that's, not precisely the same, but again, ballpark, we're seeing that within the CBSA price variation aligning between the claims and the tick data. And now within the hospitals, as I said, there's going to be a lot of the word variation, and there's variation across all these different things, which makes it sometimes hard to keep straight. So this is within the hospital. What's that variation between the high and the low? And so on the x-axis here, we're looking at the ratio of the high price to the low price. And you see, the majority of the hospitals are going to fall between like 1.2 and 2.1. 1.5 to 2 times the price. The high prices are 1.5, 2 times the low prices. We do see this kind of long tail of there is, 10 or so hospitals there that have more than 20. The variation prices is going to be 2 to 3 times higher than that low end. So these are sort of those hospitals that have a wider range of pricing for the same service. The colors here are the median negotiated rate we see in the tick data. So there isn't a clear correlation. It's not that the places with the bigger variation had the higher prices on average. Some are all over the place. So it's again, the variation matters as well as the average price. So high variation doesn't mean high price. High price doesn't mean high variation.
Got it. A lot of variation.
I would say not a lot of synonyms for it either.
Yeah.
And lastly, because in the tick data, we can look into the payer specific rates. We're now looking at the payers throughout Pennsylvania, where each dot here represents hospital, the median rate at a hospital for that payer. And you see there's some of these plans, payers have kind of narrower ranges of their min to max rates. EPMC having kind of the narrowest. I'm looking for synonym for variation. I don't have one, but the narrowest range here in their negotiated rates across hospitals. And then when you look at the large national insurers, the UHC, Aetna, they kind of have a wider range and almost have providers across that whole range of prices. And then if you recall, like the average negotiated rate we're seeing claims data sort of in approximately 11,000, 12,000. That kind of does align right here. If we drew a line across, you would see that is similar to what, it would fall in the middle of what we saw in these rates, which isn't surprising. So again, we do see this alignment in the rates published in the tick data and the claims data, at least at an aggregate level.
And all of these payers seem to follow kind of this general trend, as you mentioned. Maybe UPMC is a bit lower. And then you've got Geisinger, which is, clearly there are some outliers here. One of the things we don't know, since this doesn't have utilization, is, how frequently are these up here charged? Or, is this data wrong? Which is, we see a couple on these other payers, but this is clearly there. So that might require further investigation.
And so for the conclusions, really, that first question is the tick data usable for market analysis? Can we trust the prices? Can we draw conclusions from that? Based on what we saw and how it aligned with the claims data, on average, yes, I think you can make conclusions and they can be reliable and they do benchmark to claims-based estimates. So that was exciting to see that alignment and seeing that the data look like how we'd expect the data to look. And it gets to that, can we replicate claims-based analysis? Yes, with the careful considerations, was all those points of making decisions as far as how to clean the analytic data set. And the other thing is that you don't have utilization. So just being mindful of that and how to present the data or even clean the data becomes tricky once you're getting into the analysis, because a lot of the how to remove outliers, or are these numbers only, did anyone pay that rate? We don't know. So it makes it hard to remove, any observations because you don't know how often a given rate is ever used. Did that payer ever have a member be a patient at that provider? No, you don't know based on the tick data.
Right. And we were talking about, we'd love your questions in the chat, by the way, on the right. So please send them and we'll try to get to them. But yesterday, John and I were talking about that exactly, like how we might combine utilization data from the identified claims with the tick data. And another thing that's changing is actually with the hospital data, they're now being required to report their kind of high and low that was actually billed in the previous year. That's a new rule that just went into effect January 1st. It won't be enforced till, I believe, April later this year. But so eventually, maybe we will get some better insights into what's actually being billed by the hospitals, but it still doesn't exactly answer the question for what we're after there. But moving perhaps in a better direction
Yeah.
there. So
I mean,
yeah,
as someone who's spent most of their career in claims data, and utilization is one of the core parts of understanding prices and spending on data, it's very easy to latch onto this. Oh, there's no utilization metric. I mean, that also is because of where this data comes from. So it's not as easy as the payers could just add it in, because it's a whole different silo. And these rates this is the rate we would pay, not this is the rate we have already paid and negotiated and gone through adjudication with and everything. So there's a lag on claims data and prices that, anyone who's done research knows about. And that is kind of the reason why we can't have use, because who knows? That is the rate they would pay, but doesn't mean someone's actually going to go to that provider.
right,
Rate would be paid.
right. It's not the actual bill. It's kind of like, I think of it as like, this is the price list,
Yeah.
right? And what actually shows up on your bill may be quite a bit different.
Yeah. So it's not as simple as they're deleting a column in their table,
Right.
and we don't want to do utilization. That's not going to, that lives in a whole different area of the payer.
It's complicated. So we've got a couple questions here in the chat. And thank you for the questions. Please submit any if you have. So what kind of time, manpower was involved to do all the steps to reduce the data to this point? So I can tell you sort of for the data preparation standpoint to get to that. We process all payers for all geographic areas like every month as they're on a rolling basis as they are published by the payers. So it may be more than a month, but it's a rolling basis as we can process it. And our machinery we've been developing this infrastructure that is specialized for processing this data for a number of years now. And I don't have an exact number. I would say several days at least, but then there's the step of downloading it from the payer servers, which can take a while. They have limits on how quickly and how many files you can download at a time. We do some special things around that as well. So I would say the data processing time, probably like 5 to 10 days. It sort of depends. I can tell you, for example, I think it was Geisinger or UPMC, ridiculously complicated data for structure. Like, I forget which one it was, and I don't mean to badmouth anybody, but it contributed the fewest rates, but was the most complicated to process. So with regional payers, we do see that often, that sometimes it takes more work. Some of the national carriers tend to be a bit more standardized, but not always. I don't know if that really answers your question, but that's the data preparation. So I would say, a week or so. But that was to do everything for all payers, across all the geographies and all providers. Once we had that, I don't know, John, like a lot of it was just us discussing, like, well, what's a good project? What's a good way to scope it? How
Yeah.
can we compare apples to apples?
And it's looking
So
at
sort of
each
like,
field and the decision making of what filters, because it's the how's it look if we do or don't include a certain filter.
right,
And the cleaning. So yeah, that's a couple week process of just looking at the data. I mean, one thing that made it faster than other is the Gigasheet infrastructure of being able to look at the data, make decisions, apply the filters to get down to the analytic data set, which is then downloadable. And that gets to, then all of a sudden it is a human level, not machine
right,
readable. It's machine
right.
readable, but it's like, oh, I can open it on my desktop. I can put it into, various statistical programs and easily then figure out what's going on. And I think that's the big hurdle with the tick data has been like, it's so big. How do you filter it down to get it to the size that is usable to start to then make real decisions and see that, that these are the rates we were looking for?
Yeah. Obviously, if we were to go to Virginia and do the same analysis on childbirth, it wouldn't take us very long at all. I mean, the actual steps were not that time consuming. It was more just the deliberation on how, what is a thoughtful way to scope this and do it. And, if we did something different, like I'd mentioned, orthopedics and total knees, I still think we would do it a lot faster than we did the first time, just because now we kind of know what to look for, but probably not as fast as replicating childbirth. Another question that came in is, do each of the DRGs pertaining to each hospital have IPPS DRG calculated rate compared to Medicare to commercial payment ratios? Is this also available for OPPS facility prices?
Yeah, I mean, they should have the rates for the Medicare payment for these DRGs do have a rate, and the included hospitals should all be Medicare. I know when Jason, when you've done the including Medicare rates, honestly, I think you did a fairly good match with that for the hospitals.
Yeah. So we can benchmark against Medicare when those rates are available. We chose not to do that as part of this analysis, but if the data has been published, yeah, it can be layered in and joined in. And we have done that in the past for other projects. Um, the where it becomes tricky is when you get different modifiers and different more complicated situations where there are various parameters where Medicare generally will say, look, like, here's just the rate. And then, but the payers obviously say, well, here's the rate if, childbirth was done in inpatient, it was in an ambulance, maybe they have a rate for that. And there are all these different permutations. So it can be done. We didn't do it as part of this project. And again, it takes some, I think you can't just simply just like throw it in and get an answer. It would take some careful thought as to how to apply that. Another question, based on your understanding of this data, would you expect a different set of DRGs like cardio, ortho, to show different conclusions due to contracting differences? John, I'll let you answer. I know what I think, but yeah.
Yeah. Yes. I think we would see definitely different patterns. I think depending on the service, you always have to, like, one of the reasons we chose childbirth is the most common. So from a sense of, is this provider going to actually perform that service? We could be pretty confident that a general acute care hospital would have admissions for childbirth. Now, if it was neurosurgery, all of a sudden they could have a posted rate. It seems like it might be feasible, but that hospital would not, you know, really perform that. They would refer to a larger hospital. So once you get into, other specific DRGs, I think you have to take any institutional knowledge and information outside of the tick data to then make the decisions on, what to include, what to look at. And one of the complications with, all inpatient care and true with outpatient as well as like there's still physician bills that come in as well. So from a patient perspective, that single service is really many services and bills from different providers. So some of those contracting differences that might be because of large group practices or consolidation on the physician side or change in ownership structures might not get captured. You just have to, again, take market knowledge and other things to be like, I think I know what's going on here or how to identify, what I'm looking for.
Right. I would say one thing that's consistent is it's inconsistent, right? It will vary, again, variation. I don't know that you would see the same patterns in ortho or cardio, for example. I do think you would see variation and large differences in prices, even in the same geography. We see that. Kind of along the lines of what John was saying, I might look at CPT codes instead of DRGs as well. With CPTs, we could limit it to just orthopedists for total joints, and we could limit it to cardiologists and kind of compare it that way versus the hospital rate. We can certainly look at those as well, but you need to have a little market knowledge. So one follow-up to that question was, yes, you saw the Medicare rate column and you were looking for clarity on that. Yeah, we do have that. We didn't bring it in for this project. Let's see if I can bring it up and maybe show it for some other codes. But so what was included in that file is from the physician fee schedule versus the hospital rates. And what I was showing was the whole data set for Pennsylvania versus just the
Yeah.
smaller slice that we had looked at.
I think one of the complications, and it's not insurmountable, is at what level to merge and combine data, particularly Medicare rates. So for IPPS, if it's the CCN level data, like that doesn't crosswalk super easily, or with a tax ID or with a NPI. It's feasible, but it's sort of sometimes needing a intermediary crosswalk or something like that to carry in and pull in. Um, the IPPS or OPPS rates.
Right. So we do have the data when there was a match. We didn't explicitly go after the hospitals.
Yeah, and
That
those are
was,
the physician ones, which I think,
yeah, yeah.
just
This
be a
is
little easier on the crosswalks.
That's right. That's
Yeah.
right. It's doable, like you said. It just gets a little more complicated, and for purposes of this project, we did not put it in scope.